about this event. We are the organizer. I'm from Prime Magazine. I'm Jenny. And we have Dr. MCT, who is also co-organizing this event with us. This month, we decided to do Alzheimer's because it is actually Alzheimer's month as well. And rightfully, Dr. Han actually just, Dr. Seng. I keep calling him Dr. Han because of the way that, we read the surname as the last name, okay? Together with Prime and MCT. MCT is a Singapore-based, healthy oil company, and they can benefit your brain and energy for your body. And as you know, my magazine, it is targeted at people, embracing healthy life, okay? Let us start with a brief introduction of Dr. Seng Kok Han. Dr. Seng Kok Han is a psychiatrist consultant at Noble Psychological Wellness Clinic. He subspecializes in geriatric psychiatry and was the chief of Department of Geriatric Psychiatry, IMH. So if anybody knows about this topic, is definitely Dr. Seng. He actively led the department in initiatives such as dementia-friendly ward renovation and memory clinic. He was also the project director of the Aged Psychiatry Community Assessment and Treatment Services. He is much sought by the community network and media as public speaker in dementia and depression in the elderly. With a passion for public service, Dr. Seng continues his association with IMH as a visiting consultant. He advocates for good mental health and believes that people with mental illness can enjoy satisfying, fulfilling, and value creative life. Without further ado, please let us welcome Dr. Seng on stage to share with us on dementia.
Hello, good afternoon, everybody. I see some uncles and aunties. I'm very careful how to address people. I remember when I was a very junior doctor, I called this patient Apo. How are you? And then she got very upset. She said, 我很老咩? Meaning, am I really that old? Then I said, I'm very sorry. How old are you? And then she actually said, I'm only 28. So this patient has dementia, right? But to her, she has already forgotten her age. So she actually has quite severe dementia. Yeah, so this patient has actually dementia and quite advanced dementia, so she actually cannot remember her age. So I think from that day onwards, I'll be very careful how I address people. So try to call uncle, aunties, and avoid apo, ama, or akong. So what should we discuss today? So dementia is actually a terrible disease, sometimes described as the cleverest thief, because she not only steals from you, but she steals the very thing you need to remember what's being stolen. Right? So later I'll illustrate a little bit more about what I mean by Alzheimer's trying to steal your things. And if you don't get on top of Alzheimer's, it will bankrupt the healthcare system. It is a very expensive disease because it is very chronic and it does affect the family members. Their family members sometimes have to give up their job to look after their loved ones. And you know that it actually this whole process may take years, even about 10 years. And we will try and find out more about it. So I'm going to share with you the epidemiology of dementia, maybe to also clarify and understand what is dementia. Because a lot of people think is dementia Alzheimer's dementia, or exactly what? Are there different types of dementia? So we'll clarify that. Who are at risk of dementia? I think the fact that you all are here, you actually have a slightly lower risk already. Because stimulating the brain, active learning, reduces the risk of dementia, right? We have to keep using our brains. It's just like you see people who go to the gym, right? They have to go regularly to build up the muscles. If they stop, and then they will look terrible because they all become fat. And of course, if elderly do not walk, after about days or weeks, they can never walk again because the muscle atrophy, shrink. So similarly, we have to keep using our brains. Unfortunately, a lot of people, after they have retired, they stop using their brains. That also increases the risk of dementia. So we talk about the symptoms to recognize dementia, and then followed by management, and some of the tips to prevent dementia, and we end with a conclusion. We know that basically the numbers are big. 35.6 million people in the world with dementia in 2010, and it will double, and then by 2050 we have 115 million people with dementia. I think the numbers are quite big. So Singapore has one of the fastest aging populations in the Asia-Pacific region, with 21.5% of the total population consisting of persons aged 65 years and above by the year 2025. So in 2005, 1 in 12 residents was 65 years or older, and this will increase to 1 in 5 in 2030. So meaning that, every 5 people you see, you only have 1 young to support, right? 5 young to support 1 elderly. And this is related to the increased life expectancy and, of course, our declining birth rate. In the well-being of the Singapore elderly, the WIFE study, which I was also part of it, it was found that about 10% in the elderly population aged 60 years and above have dementia. So I was told that there are about 20 people here. So let's say if 200 people here, so let's say 10%, that will be about at least 20 of us will have a risk of dementia. So what exactly is dementia? So dementia is actually a general term to describe a decline in the mental ability to remember, think, and reason. So it is not just about memory alone, because it can result in personality and behavioral changes. And very important to remember, in psychiatric conditions, we look at function. The functioning is impaired. The ability to carry out normal activities is impaired. And what happens in dementia? So the brain cells die at a faster rate than normal. And a lot of people think that it could be just part of normal aging, but it is not. It is not part of normal aging. I've seen my oldest patient who has no dementia is 100 years old. Right? So despite 100 years old, he's still very sharp and can remember things very well. So it doesn't mean that as we grow older, it is natural for us to have dementia. No. So we should try to prevent dementia. And so how? So what is Alzheimer's? Alzheimer's is just one type of dementia, but it is the commonest type of dementia. And as you can see, there are so many types of dementia. So sometimes people tend to just assume that once you talk about dementia, it's Alzheimer's dementia because it is just so common. But the second commonest is vascular dementia. So in Chinese, we call it 失智症, right? Dementia. And some people ask me, how about 痴呆症? Actually, 痴呆症 also refers to dementia, but it's just that 痴呆症 doesn't sound very nice, right? To call people 呆, right? So 失智症 would be a nicer way. And as you can see, there are actually many other causes of dementia, including nutritional causes, our heart, lungs, our head injury, alcoholism, and various, even Parkinson's disease can actually lead to dementia. Alzheimer's dementia. So this type, being the most common, is actually of a very slow onset and progression. So it's very gradual. So sometimes the relatives cannot tell me when their parents start to have dementia because it's just so very subtle and slow. There's a familiar tendency. That means when there's a family history, there can be a higher risk. But not to worry first. If we are talking about the early onset dementia, so these are the people with dementia younger than 60. So if you don't have a family member with dementia at the onset younger than 60, you should not be too worried about the risk. It's only the very young onset dementia that has a strong genetic contribution. Right? It constitutes 60% of the causes of dementia. And to make it simple, it's just due to abnormal protein formation that result in some inflammation, and it causes the brain cells to die. So basically, you can see the healthy brain on your left side is more robust, more flesh, more tissue, whereas the one with advanced dementia has a shrinkage of the brain because the cells die. And then depending on the function, because the cells die, the area that is involved loses that functioning. So you can see that in the Alzheimer's dementia brain, they have abnormal protein, we call it the amyloid plaques, and the neurofibrillary tangles. Basically, these are abnormal protein formation that results in cell death. The second commonest type, the vascular type of dementia, results from a series of stroke. Actually, there are actually a lot of people actually walking around with little minor strokes that they may not even notice or aware, right? And then over time, there may be a risk of a bigger stroke. And then all these strokes can also increase the risk of dementia. So very important, one of my relatives recently has a stroke. And actually, he has hypertension, but he's somebody who doesn't believe in medicine. So unfortunately, it was quite a distant relative, so I never had a chance to speak to him. So he's somebody managing a company, doing very well, but unfortunately, he said he just don't believe in medicine, so he refused to take his antihypertensive. And one day, he got a massive stroke. And now his speech is affected, there's one-sided weakness, and then he has difficulty recognizing people. So he's getting likely a vascular dementia, and he's only 60 years old. Right? So we have to learn how to take care of ourselves. So who are at risk of dementia? Age. So the fact that as we grow older, there will be increased risk of dementia because age itself is a risk factor. So it doubles every 5 years from about 1% at age 65. And certain genes, but as I said, if you don't have somebody with early onset dementia, you need not be too worried. Female gender, being female, you have a higher risk because I think female also tend to live older, advanced, longer lifespan. Low education, likely because people also may not stimulate the brain as much when they don't have enough education, or sometimes, of course, due to some brain-related issues, which does not allow them to have, higher education. But of course, we are also talking about sometimes even the older generation is not that they cannot be educated or they are not good, is because of the circumstances, right? Our grandparents tend to be poorer, they don't have a chance, but that doesn't mean that they cannot achieve a good education. Head injury, lifestyle, smoking, alcohol, exercise, poor, unhealthy diet, medical conditions like diabetes, hypertension, hyperlipidemia. So these three factors, the vascular risk factors, increase the risk of Alzheimer's dementia, obesity, stroke, and even depression. So depression is actually a risk factor for dementia. Why? Because when we're depressed, we probably stay alone, we don't want to do things, we don't stimulate our brains, and then we can be socially isolated, and we don't use our brain. So depression itself is a risk for dementia. And as I mentioned, social isolation. So what are the symptoms of dementia? So again, a lot of people think that it's just due to memory. So it's more than just memory. Unable to learn new information, that's what we call the short-term memory. That means you forget something very recently, like just now. Somebody tell you about something, or somebody came to visit you, and then you cannot remember. Loss of long-term memory is when you can't remember even things of the past. So sometimes the relatives tell me his memory is still very good. He remembers what happens during the Japanese occupation, but could not remember what he ate during lunch. Right? So the Japanese occupation was long-term memory. So it was encoded, and he can still remember. So in Alzheimer's dementia, there's difficulty encoding and registering information. So any new information that just happened, he cannot encode, cannot retain. Right? Judgment is also impaired, so it's not just about memory. There can be aphasia, they cannot recall words or understand the meaning of common words. Right? Suddenly, just cannot. Sometimes I just, for example, I ask a patient, Maybe what is this? So it seems that they know what it is, but they just cannot remember what is it called. Right? This one is to drink one law. They have different guessing. This one is transparent, but the mineral water or something just doesn't come out. Yeah. They also loses the control of muscle, so it's not just about memory. There's motor function, difficulty buttoning shirts, losing the ability to recognize people, cannot copy a 3D figure. I mean the visual spatial, that means the orientation of space, direction around them is affected. So they end up having difficulty trying to actually navigate or find their way back. Personality changes, unusually angry, irritable, quiet, or even confused. So in other way, one way of classification is on the different stages of dementia. You can have early, middle, or late, or sometimes we call it the mild, moderate, or severe dementia. So what happens during early dementia? People with early dementia can still carry on with day-to-day activities. So sometimes they are not being recognized that they have dementia. But more complex activities such as handling finances can be impaired. So elderly patients can be vulnerable, to be being cheated, if they are not able to be alert enough, and that people take advantage of the poor judgment and handling of finances, and they can be asked to buy certain financial products which may not be the best for them. So complex activities like this. Poor memory of recent events, like what happens just now, soon, missing appointments, word finding difficulties, misplacing items, being repetitive, that means maybe keep asking, the same question again and again because they have forgotten, taking more time to complete daily tasks, and also some personality changes. That means they are not so motivated. Like suddenly not interested in doing anything. That's what sometimes the relatives will say. Don't wish to do this, don't want to go for makan anymore, social withdrawal, and many feeling quite irritable and frustrated over little things. So this may be some early changes. In moderate dementia, the memory lapses become more obvious. More and more forgetful, even forgetting names of common objects and familiar people, losing the track of time and events. Now, I have a patient who actually, the daughter was telling me they were actually in Japan, eating. And then suddenly said, I want to go back home to Toa Payoh. So she actually has forgotten that she was already in Japan. So that losing track of time and a bit of disorientation. And then they can actually wander and get lost. Dependent on others in managing finances, medication. Sometimes the early symptoms, signs will be they take the wrong medicine or take too much medicine, like too much diabetic medicine, then make the glucose, go very low because they thought that they have not taken the medicine, so they double dose. Or of course missing medicine such that maybe the blood pressure become very high, and then because they didn't take the antihypertensive. Problems with shopping, transportation, and even hygiene neglect. Sometimes they forgot to bathe, or just insisting on wearing the same set of clothes, or thought that it was a new set of clothes. So these are telltale signs. Of course, later on there may be inappropriate or disturbed behavior. They become very irritable, agitated, and experience even hallucinations. Now, hallucinations is what we call it. It means your senses. So you hear something or see something when actually it's not there. For example, they may see, like recently I have a patient who actually see the deceased husband. Right? So having a hallucination of the husband coming back to visit her. Right? Or sometimes auditory, maybe in the form of hearing things, people talking to them. But the most common is more visual in dementia. That means they see certain things which are actually not there. And they may even have delusions. Delusions are what we call false belief. So they may believe that people are stealing their things, when actually they actually misplaced their things or they have forgotten. So they become very suspicious, or thinking that the helper or the daughter-in-law commonly want to harm them, poison them, things like that. Huh? So these are some of the behavioral issues that may result. Okay, let's try to understand a patient with behavioral problems. Huh? Let's imagine this represents our life. You know? We have motivation, we can take bus, we have memories, we get respect, you know, we're able to read and write, we can do housework. But slowly, we start to lose them. Just now I talked about dementia being a thief, right? So with time, we actually lose some of all these abilities and memories, and we lose functioning, and we lose more and more things. Eventually, the brain is like blank, right? So you can understand why some patients sometimes can suddenly feel very agitated or even fearful, right? Hey, suddenly, how come there are so many people staring at me? Because you do not have this background experience and learning and memory to help you already, right? So that can make them very fearful, agitated, defensive, resistant. So I think it's important to understand them. So they end up having mood symptoms. They can have depression, anxiety, euphoria means extremely happy also, elated mood. Now I have a dementia patient who's very cute. He thinks that he's extremely wealthy. Right? He said that he has 10 wives, he's the richest person in Singapore, and just now just had a chat with Mr. Lee Hsien Loong and all that. Yeah. So a bit of grandeur, thinking that they are very special and all that. But sometimes you must double check, you know. Yeah, sometimes maybe really is a friend, right, of some important people. And apathetic, maybe just don't want to do anything. Psychotic symptoms, I mentioned delusion, hallucination, and sometimes misidentification. Also very common because of the memory. A lot of times when the son maybe accompany the elderly patient and ask, who is this person? Often they can tell me that this is my husband. I even have those saying that this is my father, right? Misidentifying. They also can have sleep-wake cycle. This can be challenging because now they are sleeping in the daytime and they are wide awake and doing all their activities at night. And then the family really have to suffer, right? So we have to readjust the sleep cycle. And can have sexual disinhibition. Sometimes they may want to expose themselves. I have nursing home patients who will end up touching female staff and things like that. And even aggressive behavior to protect themselves. They can be resistant to care intervention, and even unprovoked, they can be agitated or noisy. In severe dementia, that's when they become more and more dependent on these activities of daily living, such as dressing, bathing, toileting, eating. They will need help. And they can maybe not even recognize family members. Language is restricted, may not comprehend what is being said, and eventually even loss of speech. And there will also be loss of continence, so they need diapers, loss of mobility, and constant supervision is then required. So this will be the final stage of dementia. And so, actually at every stage, it can last 3 to 5 years, right? So you can see that with the years of onset, it becomes more and more severe and becomes more and more dependent, and there will be more and more burden, to the family. Right? So I think a lot of times, I've seen some seniors here. Are you actually very worried about being a burden to your family members when you grow old? Yeah. So this is a common worry I see in my patients. But I want to reassure them that it is okay to be a burden if it happens one day. Because you were the ones who actually brought them up, right? You have done a lot, right? So it's only natural and it was only right that you give them a chance to also do things for you. So I will tell them not to feel that. In fact, it is a good chance for them to do good. And in fact, it's good for their children to actually see and observe so that they will be well taken care of by their children. Right? So don't ever feel burdened. Of course, we try our best, not to burden them, but really, sometimes there's no choice. I think we should allow them to know what is care, what is unconditional love and all that. And I must say that a lot of caregivers have actually grown and learned from this caregiving process. So they have not lost. In fact, they might have gained. So what is the benefits of early diagnosis and intervention? Unfortunately, dementia, there's no cure, right? We only have things to slow down the process. Then people will say, so if there is no cure, then no need to see doctor, no? Just continue to have dementia. But of course, during the process, without the understanding and preparation, it will be and maybe control some of the symptoms, it will be very difficult to cope. So we need to educate them to improve understanding, and sometimes need to plan for the future, like writing a will, lasting power of attorney, LPA, while they still have the capacity. Don't wait until totally cannot make decision. At that time, you cannot write a will and cannot do an LPA, and it will be more costly to get the lawyers, to help you. Recently, lawyers tend to refer patients to me to certify that they're actually fit to write a will, even though they're actually very well, very clear. I suppose after the tour guide problem, people are more scared and want to be quite cautious and make sure that the elderly is really alert and of sound mind so that nobody will challenge that will or the LPA. And we also need anticipatory guidance for emerging symptoms so that we are prepared and know how to deal with dementia. Referrals to support group and community resources are also important, and also intervention to slow down the progression of the cognitive decline so that you want to prolong the elderly from being able to continue to function in the community and delay going to a nursing home, because nursing home is expensive. And I'm sure none of us would like to stay in a nursing home, right, if we can avoid. And sometimes it pains the family to have to send their loved ones to a nursing home. So we want to delay going to a nursing home. How do we manage? So just have to remember that it has to be a multidisciplinary approach, and that every need of the patient, each patient and family has their own different needs. So no two patients are the same. And we want to assess the disability, the needs, and the functioning. We want to know the extent of the deficits. We want to know the difficulties they have in their everyday life, like getting lost, driving, medications, finances, shopping. We want to assess the behavioral and psychological symptoms of dementia, whether they are aggressive, whether they are depressed. We want to know whether there's a family history of dementia, the medical history and medications, and look into some of the medical legal issues, and also caregiver stress issue. I have caregivers seeing me because they are so depressed to the extent that they need medication, right? Because to them, they are just so burnt out also. We need to assess the risks. What are some of the risks that can happen in a patient with dementia? So they may wander out, right? They may have poor judgment. They may leave the gas on. They may leave the front door open. Dangerous driving, self-neglect. They may be vulnerable to abuse and exploitation. And they can be aggressive and disinhibited behavior. So these are some of the risks. And in the assessment, we also do mini mental state examination, or some of what we call the Montreal cognitive assessment. Basically, we want to test the memory. So we will ask them the day, date, month, year, and all that. But of course, sometimes we understand that the elderly sometimes don't look at the calendar. So we also take into account. And we also, ask them to remember items, and then after that, make them recall again and all that. So, but we'll also definitely have to take into context the education, right? Sometimes they don't know, not because they are demented, but it's maybe because they are not so educated, right? So it's important to know the culture and all that. So it's very interesting. I have this elderly lady who has definitely dementia, and I was doing one of the tests in the Montreal cognitive assessment. So this test requires you to name as many animals as you can in 1 minute. It's not that easy, because if you have dementia, you have difficulty trying to remember, or even, so I have some patients who just can name me 5 animals, can think of maybe 6. But this patient, although she's quite severe dementia, she actually had a full score, You know how she did it? She said, 一次几股3号四头golling. So some of you laughing, you may be familiar with the Chinese zodiac signs, the animals. So actually, in a way, it's cheating lah, but because of the culture, because the Americans or the Angmo who developed this test, they don't have this, you see. So for them, probably it will really be a good test. But for our culture, it may not be such a good test because others she can't do, but this one she can do very well. Yeah? So we had a good laugh even with the son. And because everything she scores so badly, but this one she scored full. But I told her that actually you named 12, but I count only 11 because dragon is not counted as an animal. Yeah? But yet she still scored full because the criteria is to have 11. So it's quite interesting sometimes when you do all this testing. And then we also do physical examination, just look for neurological signs and symptoms. Sometimes we do blood tests to make sure that these abnormalities will not affect their cognition, their thinking, or their memory. Because sometimes if you have a vitamin B12 or folate deficiency, you actually can have poor memory. Thyroid function is also an important test to do. And we do a scan to see whether there's a shrinkage of the brain. Okay, looking at medicine. So there are actually only two main classes of drugs for dementia. These are the cholinesterase inhibitors, donepezil, rivastigmine, galantamine, and memantine. So they have modest effects on cognition and activities of daily living, behavioral and psychological symptoms, and unfortunately, not all patients respond. So unfortunately, I must say that we don't have good enough medicines for dementia. But we also cannot blame our scientists because the brain is such a difficult organ to study. Other parts of the body, I can just take a bit of biopsy and we can study a lot. But we cannot happy just take a piece of brain out, and just do some study and all that, right? So it is very challenging for this area in the brain. Right? Okay, how does this medicine work? The cholinesterase inhibitors, basically, acetylcholine is a neurotransmitter or a chemical messenger involved in memory, learning, thought, and judgment. So we need this. So the medicine will block the enzyme so that the less of this neurotransmitter is being broken down. And you allow more chemicals there, and hence you slow down the progression of the illness and even sometimes improve the behavior because they are actually more alert. Right? And it is useful for the mild to moderate dementia, not so much for the severe, although recent studies have shown that even severe dementia, it may be beneficial. So it's more the moderate, mild to moderate, the Alzheimer's, and the vascular. In fact, other types of dementia, even worse. There are actually no even very good medicines for that. Not even up to this level. And patients will ask me when to stop. So when it's so severe that we find that there's no function we want to preserve, we will stop such medicine because you are just wasting money. Right? You don't just continue and continue when it is giving zero benefit. Side effects are actually quite tolerable. Some people have a bit of nausea, vomiting, diarrhea, abdominal discomfort, insomnia, and it can make the heart beat slower. So you want to be careful about that because you don't want them to have the heart beating slower and then they faint. Right? There's also a rivastigmine, which has a patch form, which gives you less gastric side effects. Memantine is another one for more moderate to severe, not so much for the mild. It regulates the calcium across the membranes to protect against neuronal death and fewer side effects. Also have few side effects, dizziness, headache, and constipation. But sometimes this medicine can make the patient more agitated, so we must also be careful. And sometimes we no choice, we have used other medicines, like the antidepressants, if they are depressed, antipsychotics, if they are hallucinating. I have some patients who can be shouting. Sometimes we use a bit of mood stabilizer to stabilize the mood. Some hypnotics or sleeping pills. Of course, you must be careful. Medicines have side effects. In elderly, they are prone to falls, right? Unsteady gait, and drowsiness. So we must be very, very careful how we use, and we should use low doses first. And for stroke-related dementia, good control of the diabetes, hypertension, aspirin use sometimes can prevent further clots. So these are important not to neglect too. Now I move on to the non-medicine approaches, the non-pharmacological type. Person and family-centered approaches emphasize the need to understand the life history and social cultural background of the person with dementia. So if I can avoid some of those antidepressant medicine or psychotic medicines which cause more side effects, I will try to avoid. If we can use what we call the psychosocial approaches, some methods to help them cope. Just to give you an example, there's this patient who is very violent, agitated, aggressive, tried a lot of medications, didn't really work. Then somebody has a very good idea, and it worked, and it involves no medicine. And the savior was a doll. It was found out that she used to be a nanny, right? So when she was given a doll, she started cuddling and playing with the doll, and it becomes easier to manage her behavior from that day onwards. Right? And because of that, you don't have to use high doses of medicine that causes a lot of side effects. So it's very important to understand the person behind the illness. I once had a patient in the ward who was trying to keep things. So she will keep all the nurses' files, stationery, everything. And every time they have to hide and seek and find those things. And found out that he actually used to be a Karanguni man. So he will actually hoard things and keep things and hide things. And we need to empower the caregivers through education, skills, and training. Look, you remember this calendar? I have this patient who actually cannot manage $50 a week because every time she gets the wrong change, she lose them, family get frustrated. But actually, the family member came up with this brilliant idea. She actually staples $6 in a plastic bag onto every piece of the calendar for that week. So every day, she tear one piece and use that $6. So it's like a voucher, right? So then she just needs to know how to manage that $6 for the day, which is very easy compared to $50 for the week. Now, this is an example whereby, we have to use some of these methods to help them, and we have to be quite creative. Instead of giving her antipsychotic because she's paranoid that people steal her things, and then you give her side effects and other things. Right? So in the late stage of dementia, maybe what function they have left probably is to just feed themselves. So I had a patient who actually, in this long process of dementia, and then the caregiver actually shared with me, and this was the first time actually I had a good illustration of what is person-centered care. So a lot of times actually we learn a lot from our patients, and we share with other patients. So she said that what kept her going was a photograph of the mother when she was younger. So that reminded her of the mother, and she knows that this is an illness, an ill mother. So the mother didn't mean to be agitated, didn't mean to be toxic with her words, didn't mean to be so difficult. It was the illness that made her so. So this was a picture. This was not the exact picture of her mother, but it looks something like that because they have very old hairstyle, right? This type of hairstyle. So she showed me something like that, that reminded her of her mother, and that kept her going. Do you all know who is she? Ling Tai, not Li Li Hua. Some people guess wrongly. So this is Ling Tai. So other non-pharmacological management is including behavioral therapy, reality orientation, cognitive training, art, music, reminiscence therapy. So I won't go through everything. I just want to highlight a little bit about reality orientation. So we want to help to maintain a sense of what is actually going on around him or her. Maybe some daily whiteboard to show routines, calendars, big clocks, labeling certain rooms, reading newspapers together. And in behavioral management, so it is basically to understand the behavior, as I mentioned before, and that to know what triggered the certain behavior, what was the actual behavior, and what could be done to handle the behavior better. So sometimes I refer to psychologists to help them, handle some of all these difficult behaviors. And what are some of the common triggers of difficult behavior? Sometimes they can be sick, infection, we call it delirium, any pain, discomfort, any unrecognized need. For example, they are feeling hungry, fearful, alone, or need to go toilet, or there's any change of environment, or they may be depressed, or having hallucinations or psychotic. So it's like a baby crying, then we need to guess why the baby cry. So similarly, if there's a difficult behavior, we need to try and find out what could be contributing to the difficult behavior. And of course, we also need the social aspects like education, training, caregiver support, to help with the caregiver, like the Alzheimer's Disease Association, day centers, home help, sometimes nursing home, or respite care. So I had a caregiver who was very stressed. So I said, maybe you should take a break, go for a holiday. So she will send the mother to just a 2-week stay in a nursing home so that she have a good break. Then after that, she continue the care. And of course, driving assessment and looking into like the will and the lasting power of attorney. So I think to care for patients with dementia, we need to be patient, and I said empathetic, to put yourself in the patient's shoe. We need to communicate well, talking softly, simple sentences, and try to avoid argument. Sometimes there's no point arguing over certain things. We need to simplify activities for them, but at the same time, we need to encourage independence. You want them to do as much as they can so that they can continue to preserve the function. You may want to maintain a regular routine, which includes exercise and activities. Have some structure so that they don't feel too anxious. We need to create a safe environment. We need to remove triggers to difficult behaviors. If you have a picture of a kampong that reminds her of wanting to go back to the old house, or the old house is still there, please remove it because that will cause her to be agitated. Be flexible, use distraction techniques. Instead of insisting to go out, let's drink some water first or look at pictures first to distract her. And of course, if the behavior is not hurting anyone, just allow him or her to continue. Good to keep some photos handy, like a bracelet or a safe return card in case they get lost. So how do we prevent dementia? Something for ourselves. We want to try to maintain good control of blood pressure, diabetes, and cholesterol, have adequate sleep and rest. It has been shown that some people who have less than 7 hours of sleep a day have the risk of shrinkage of the hippocampus or some part of the brain that's in charge of memory, right? So I think adequate sleep is important. Eating healthily, I understand that you have a nutritionist speaking later. Eat healthy, exercise regularly, avoid smoking, be socially active, and continue to be engaged in mentally stimulating activities to keep up with current affairs and lifelong learning. So in conclusion, it is important to recognize the early signs of dementia and seek help early so that we can do something. As disease progresses, patients need more and more care, and this can be hard on the caregivers, affecting the family life, job, and finances. But I always like to end with something positive in the sense that with early diagnosis and intervention, dementia sufferers and their families can also be helped to prolong the time where they can enjoy productive and fulfilling lives. I think it's important to remember that, which is well illustrated by one of my caregivers. She said that my mom taught me patience and unconditional love. It was so difficult at the beginning, but I feel that I have grown, become wiser, and won over myself during the process. It took me time to see the meaning, but I saw it finally, and I'm grateful to all those who have supported me. So it's not all negative. There are people who actually learn and grown through this caregiving process. And just want to end by saying, this is my favorite quote. It says that death is more certain than tomorrow, than night following day, than winter following summer. Why is it then that we prepare for the night and for the winter time, but do not prepare for death? We must prepare for death, but there is only one way to prepare for death, and that is to live well. So I'll let you go and think what is living well. Try to enjoy your day and not over-worry about things. Make the best out of things. And of course, we try to keep ourselves healthy, both physically and mentally. Thank you very much.
Thank you, Dr. Seng, for this insightful sharing. Now we are here to answer questions. I believe some people are asking for the Wi-Fi password. Let me give you the Wi-Fi password here first. It's you go for LLI guest if you're searching for the password. It's LLI 40 8601. Okay. Dr. Seng, you would like to answer the first question?
Sure.
Is it true that if my mom suffered from Alzheimer's, I'm likely to suffer from it too?
Okay, this is a very good question. As I mentioned, so I want to know whether your mom has dementia at the onset less than 60 years old, because if she has early onset dementia, your risk will be higher. But if she's already in the 70s, 80s, your risk will not be much higher. So you don't have to worry about that. But this also leads me to think about this study, which actually shows that spouses, if the husband has dementia or the wife has dementia, the other partner also seems to have a higher risk. Why? They are not genetically related. So some postulation, it could be related to because couples do things together. They eat the same unhealthy food. Their lifestyle is the same, potato chips, watch TV, or whatever, you see? Or maybe they don't exercise, right? So sometimes it could be that.
Okay, the second question is, with dementia, my mom cannot sleep at night. Why is this so? I do not think it's a good idea to keep on giving her sleeping pills. Thank you.
Another very common issue. So why do they cannot sleep? A lot of reasons. A lot of elderly actually tends to lie in bed the whole day. For example, they keep just lying on the bed. And as we grow older, actually, we need less sleep. And then if you still rest so much in the day, so quite naturally at night you can't sleep. And you don't do anything. So you also don't expend energy. So I always encourage people to get them involved in activities, to do things so that they are tired. And I think it's good to have good sleep hygiene, things like avoid coffee, tea, maybe just in the morning, right? Some exercise, but the exercise should not be too near the sleep time. If it's too near the sleep time, it's overly stimulating also, right? And then it's good to maybe make sure that they're not worrying excessively. That can also affect the sleep. So there are many factors, so good to let the doctor know. I do agree that sleeping pills should be used as short-term as possible and can be avoided if possible, because it leads to fall and all that. But sometimes we have to balance the risk-benefit ratio because the quality of life. If you can't sleep, it really feels terrible. And make sure that they don't sleep the whole day in the daytime.
We will skip the next question because we'll leave it to the nutritionist to answer. I think that's fair, right, Doctor?
Yeah.
Okay.
Yeah.
Which organization in Singapore are doing research in dementia?
Oh, definitely. IMH is where I'm still a visiting consultant, so they will actually do a lot of research in dementia. In fact, the WISE study, and I'm sure all the general hospitals are also doing studies in dementia as well.
And then the last question we have at the moment is, why do my mother wants to visit the toilet so frequently when she actually doesn't have urine, or stool?
Good question also. Many possible reasons. First of all, I think we also must exclude medical condition. If they have a urinary tract infection, a UTI, can cause irritation that make them want to go toilet very often. So sometimes I just do a simple urine test to make sure there's no infection. But of course, it could also be behavioral related, or it could be even anxiety related issues. So again, you have to look out for all these anxiety problems and treat accordingly, whether they are depressed or anxious. Yeah. And of course, we also may want to do some behavioral approaches, like maybe getting them involved in things and occupied so that they don't just sit there and keep thinking about whether they have urine or not.
I think the last question on board here is, does person with diabetes have risk of contracting Alzheimer?
Yeah, diabetes is one of the vascular risk factors, as I mentioned in one of the slides, one of the vascular risk factors to result in an increased risk of Alzheimer's dementia. So the three vascular risk factors are hypertension, diabetes, and cholesterol.
Any questions from the floor? If not, let's give Dr. Seng a big round of applause.
Thank you so much.